about topic, but it's an issue that's like affecting 81% of women. So 1 out of 3 women actually suffers from it. And because, you know, you just get embarrassed to go and talk to your friends about it, or even go to your GP to just like open up about it. And unless you get asked about it, it's an issue that is very common. You're not alone. So you're free to come as long as you choose the right doctor, a doctor that actually takes care of like do women's health. Because they'll guide you through everything. Okay, so I'm Dr. Liz. Just call me Dr. Liz, and I've been taking care of women's health for the last 25 years. So bladder incontinence, as we know, knows no barriers at all. So young and old, male and female, across socio-economic groups, it just causes distress regardless of where you are, what you are, who you are. So it's just because when you lick, you feel wet, you feel uncomfortable, and you smell. And so the effect on the ladies, a woman's self-esteem, and mental and psychological health is actually worse or more burdensome than the physical issue with that. So we'll go to the next slide in the next 30 minutes. So next slide. I don't know if we could go to the next slide. Yeah, so if we could probably go to the next slide, is that okay? Yeah, okay. Thanks, Victoria. Yeah, so the next 30 minutes, we'll talk about bladder incontinence if we have time. We'll talk about cervical screening, but I think I would emphasize more on the bladder incontinence because we have to like make sure that we bring across things that we could still do until we get seen by a GP. So we go to the next slide, and it will tell us, next slide, it will tell us the, sorry, yeah, so that's what the statistics are. So 5 million Australians, 1 out of 4 Australians, men and women, are affected. 1 out of 3 women are affected. So after motherhood, when we get pregnant, after we get pregnant, or even during pregnancy, 75% of pregnant women and young moms actually started to leak during their pregnancy. And just 2% actually do their pelvic floor exercises, even if our carer, maternity leave care, tells us that, oh, you have to do your pelvic floor exercises after you deliver, but just 2% does it 3 times a day. 81% of women has leaked in their lifetime. So as you know, 6.5 years is the time when women wait before they have the strength or they have the confidence to actually ask somebody for help. So imagine 6.5 from the time you leak, plus the effect of that. It's projected. They said the prevalence of incontinence in the next 10 years could actually go up from 5 million to 6.5 million. Very significant is actually the effect, or even the financial or economic. I haven't put the slides on that economic effect of total financial cost in 2010, according to a study done by Deloitte Access Economics. The total financial cost, excluding the burden of the disease, is 9,014 Australian dollars per person. So that's 42.9 billion cost to the government to take care of women who actually does get incontinence. So that would be those who actually said, I'm incontinent. Those who hasn't actually said and asked for help, they haven't counted it. So we include the monetary value of the burden of the disease. In 2010, it actually went up. Add on 23.8 billion, it actually goes up per person cost of 14 Australian dollars per person with incontinence. So that pushes up the cost of government to take care of actually the health system expenditures, formal care and aids productivity loss of those who are incontinence, as well as productivity losses of the carers and the family who takes care of them, as well as the dead weight losses. It's like 14,014 Australian dollars per incontinent person. So that's it. That's really, really high. So we go to the next slide. Next slide. Risk factors. So we'll just go through this quickly because as what I've mentioned to you, pregnancy, the hormones of pregnancy, the weight of the baby as we carry the baby has too much pressure on the pelvic floor. That's why when our obstetrician actually talked to us, they said, oh, start your pelvic floor exercises when you're pregnant and then even after you delivered. So it's more the pregnancy itself, because of the effect of the hormones of pregnancy that has that effect on the pelvic floor. That's why it's weakened. It weakens. As you grow a little bit older and that you go to menopause, the weakness actually worsens. So if you start getting those pelvic floor exercises going early on and you end up getting that routine exercises, it becomes stronger. You'll end up not getting all those issues about leaking and incontinence. Obesity because of the weight pushing on the pelvic muscles, genetic predisposition given, urinary tract infection. So if you actually don't have incontinence before and you have acute onset of just leaking, make sure you go to your GP and get checked for infection because that's very common. Constipation because you strain. So anything that you sneeze, cough, or even if you like jump and you leak, that's stress incontinence. That's a problem. You have to ask for help. Surgery like hysterectomy, when you remove the uterus and everything else, you have the risk of incontinence as well because everything falls down. The ligaments just fall down. Neurologic issues, musculoskeletal conditions has to be ruled out before you go for your pelvic floor exercises. Health conditions like diabetes, stroke, heart conditions, maybe because you have all those medications that could actually affect and make you pee a lot. So those common medications, blood pressure medications, heart failure medications, they're the common culprit for leaking. Go to the next one, please. So this is the slide, a very busy slide, but this I think would be the slide that you really have to like go home with, because if you do actually experience anything of this, any yes answer to any of these questions, it means that you have a leak incontinence problem. So you could read through with that if you feel that you could not completely empty your bladder. So you pee and you feel like, oh, there's something there, but you can't pee it out. It means that you have to go see your doctor. Or if you rush to go to the toilet, like you're okay, you don't feel like going, but then just like a sudden rush and you can't wait, it just leaks. That's a main issue as well. That's another incontinence problem. So if you have, you become nervous and you just can't control your bladder and you pee, even if you haven't drunk anything, another issue, urge incontinence is what you call it. If you wake up twice at night, okay, but if you wake up more than twice because you have to pee, it means that that's nocturia. You have to ask help as well, because one of those issues would be diabetes. Have to rule out all those medical issues. So if you leak before you go to the toilet, can't wait, urge incontinence, or like using your abdominal, intra-abdominal muscles to actually get all those sneezing, coughing, laughing, and you leak, that's another problem. Or if you exercise, the same thing, or change position and you leak. So anything that makes you leak actually, and makes you think that, okay, I have to go somewhere new, I have to know, and I have to sit near the toilet, or like Google where the toilets are, wherever you go near, that's a serious problem, because you shouldn't be doing it. You should ask help from your GP, or even the continence nurse or a physiotherapist, and we could refer you on to the specialist if you need to. Okay, so we'll go to the next slide, please. So yeah, where to get help? You come to us. A women's health doctor would definitely go through and guide you through where you go. If we need to refer you to your gynecologist, in the meantime, we could, because they could do a lot of stuff to identify which kind or type of incontinence you have. So the pelvic floor physiotherapist would also be a first point of entry if you have a feeling that you have stress incontinence, because they could help with the pelvic floor exercises, and they could help with the bladder training, which is different. Pelvic floor exercises, well, I could probably give you a really quick instruction on if that helps you, but ideal to actually see the pelvic floor physiotherapist. The best way to actually go through with it is click on that website, and it actually gives you, you click on that website, you put in your postcode, and it will guide you through to where you could find a pelvic floor physiotherapist in your area, because it's not just a physiotherapist, the specialist physiotherapist who helps you identify where your pelvic muscles are, how your exercises works, does it actually, are you doing it right, are you actually strengthening the right muscles. So that's how they do it. That's how they identify to make you do it correctly. Continence nurse, mostly in the government places, but not very common. You can't just find an independent person for that. And then we'll go to the next slide, please, as well. So the next one is very important. This is an important slide, because you have to make sure that you're actually identifying the right kind of incontinence, because there are the 3 common types, but some patients actually have mixed incontinence. So even if they have mixed incontinence, you have to actually treat them according to what is more prominent. So if they have mixed stress or urge incontinence, you have to like determine which one is more the diagnosis. So stress incontinence means, that's what I call sneeze, cough, and jump. So you're okay, but when you sneeze, cough, and jump, you leak. So very common would be girls, women's actually between 40 to 60-year-old, who's fine, but when they go to the gym and they jump, they leak. So it just makes them, they enjoy exercising, they enjoy going to the gym, but because they end up leaking, they don't anymore. So it just impacts their enjoyment, their life, and everything else. Urge incontinence, very common on ladies who's more than 60 years old or even earlier. You have to rule out that there's no multiple sclerosis or any neurologic issues that actually could make their bladder irritable. So with this condition, some people actually doesn't have to have that overfilled bladder, but anything could just stimulate it to actually spasm, and they end up getting the urge incontinence. They just can't stop it. They're fine, and then anything stimulates it, it spasms, and you leak. Before you arrive to the bathroom, you've already peed yourself, you've already leaked yourself. So very important to know which one you have, because the difference, or like even the exercises or even the management is different. Overflow incontinence is more for patients who had already medical issues like stroke, and their bladder is just like that. When they drink, it flows, so it's overflow. Go to the next one, please. So investigations, when you see your GP, the first thing they do is actually check the urine. And then with me, I always make sure that there's no structural issues. So I give them a request to check the urine, to check the kidneys and the urethra, and then the bladder, just to make sure there's no masses, nasty issues that could actually cause it. And then sometimes we measure the post-void measurements. So you go in, full bladder, and then they do the ultrasound. And then after that, the sonographer will get you to pee, and then you come back and they measure what's left in your bladder, if you could completely pee everything. So normal is between 50 to 200. Over 200, after you peed a lot, it means that you're retaining urine. Less than 50 is best, because it means that your bladder is really good. Urodynamic studies, they usually order that if they can't determine if it's incontinence, which is like cough, which is the cough, jump, and sneezing, peeing, compared to can't wait. because of, as what I mentioned to you, management issues with that. So yeah, so when you go to the specialist, that's what the lady is doing. You just sit down there, they put the catheter in, and they determine if you have, you know, irritable bowel. So they fill your bladder and they measure the pressure of the bladder, because a little bit of feeling, if you have irritable bowel, it just spasms and give you the urge to pee. So if you go to the next slide as well, thanks, Victoria. So the next one is, yeah, so we go to the stress incontinence, where you actually, most common is when you're pregnant, you have that obese patient. So conservative management, before you wait for your specialist appointment, we could still do something. Even at home, try to bring down your weight less than 30 BMI. And your GP could actually try, if you're menopausal or you're dry around the area, around 50 years old, 52 years old, they could give you or start you with estrogen vaginal pessary. And that's when the pelvic floor muscle exercises, which is the Kegels, works very well. So continence pessary, that is if you exercise and you just pee when you exercise, there's that specific area there they could actually measure, small, medium, large, and they put on the urethra to stop you from leaking. So surgical, if all this, 6 months of doing the conservative management, not working, and you're still peeing and it affects you so much, we refer you to the specialist and they do the tape, which works very well, like 78%. Complementary treatment, laser, erbium laser is actually recommended by, well, I mean, the RANSCOG, which I'm a member of, the Royal Australian New Zealand Obstetrician Gynecologist. They're happy for us to do erbium laser, like the Mona Lisa touch, for mild incontinence. Moderate to severe, we can't, it doesn't work. Go to the next one, please. So this is another slide, which is busy, but I feel like we need to actually just try. So this is what I actually give out to my patients to try on, to see if they could, if actually works and if it actually does strengthen their pelvic floor muscle. So this is really ideal for those who has really weak pelvic floor. Even my 65, 70-year-old patients that does definitely leak, I give them this copy, and it's like it just improves their leaking. So they just keep going with that, and they don't even have to see the physiotherapist. Very easy to do. Try to do it as much as you could. I would tell them, maybe when you sit down for a meal, try to do as much as you could, because otherwise you can't remember when to do it. So every time you sit down for a meal, and if you eat 3 times a day or even 6 times a day, it means that you've done it 3 times a day or 6 times a day. So if you could probably get a screenshot of this and try to do it as much as you could across the board, even women who doesn't have any kids at all, still do it, because as you get through menopause, aging actually affects the muscles down there. So it's just like, you know, your biceps and triceps, you need to actually condition it so that it supports your pelvic floor. Otherwise, your uterus comes out. Okay, if we actually go to the next one, please, as well, Victoria. So that's stress incontinence, the one that I've just mentioned to you. Stress incontinence, like, you know, coughing, sneezing, jumping, you pee. This one is the next common one, urge incontinence. It means that your bladder is just overactive. You just have those stimulant to actually makes your bladder stimulate, and when it does, you can't stop. So this is the kind of incontinence where medication works. So when you go to your GP and you say, oh, I have this kind, so they just can't hold. So get medications from that, trial of medications, plus bladder training, which I could probably go when we go to the next one slide. There would be where the bladder training is. And then Botox actually works in that as well as like nerve stimulation, which is, the nerve stimulation is 80%, 70% effective, the same as Botox, as long as they put in correctly. Botox, however, does have the risk of urinary retention. So 21 out of 20 women who had Botox, like 100 units intravesical, like inside the bladder, actually helps, but it does have the risk of retention, while the nerve stimulation is effective as well, but very invasive. So this is the bladder training for those who actually have, like, you're sitting okay and then you just have the spasm of bladder and you can't even reach the toilet, you pee, you leak. So bladder training is when you actually train yourself that when you have that urge, you're not full, but you have that urge to go, try to sit down, relax, do your pelvic floor muscle exercises, deep breathing, and try to prolong it for like 10 minutes. And then maybe the next time, 20 minutes. And then later on, you'll end up getting that 3 to 4 hours in between peeing, because that's it. It's just learning good habits. When you have the urge, try to do, like, push it up. Pelvic floor muscle exercises, deep breathing and concentration until you actually space out between the toilet breaks, and then enough for the bladder volume to actually collect enough of water or urine. So what we advise women, because they feel like, oh, I'm leaking all the time, I'm gonna stop drinking water. It's not a really good advice. You still have to drink enough, 1,000 roughly to 1,500 fluid. The reason being is because if you have concentrated urine and you're so dry, that concentrated urine actually triggers the spasm. So it worsens the condition. But if you have enough and it dilutes everything, it's much better. It does not trigger the bladder, but you just have to do your bowel bladder habits. So avoid irritants, alcohol, drinks with caffeine like coffee, tea, cola, chocolate, and carbonated drinks, fizzy drinks, does actually worsen it. So you reduce it to 1 to 2 cups a day and avoid drinking like 2 hours before bed. Go to the next one, please. That's the sample of the bladder diary so that you will know. Ideally, try to do your bladder diary like 3 days before you go see your women's health doctor or your specialist. So that's a sample of that. And then we'll go to the next one, please. So yeah, so I think we're almost done with our presentation. And as what I've mentioned to you, this is a new, not a lot of specialists offer that, because how they do it is they have to put you either in their rooms or in the theater where they put a camera inside the bladder and they do the injection on the surface of the bladder. Very effective though, it's 70% cure rate, but they don't do it. They don't do it if you can't self-catheterize, because sometimes your bladder muscle are so relaxed in such a way that you end up getting the urinary retention. So if you can't self-catheterize, it worsens and blows up your bladder. So if you go to the next one, and please. So the other complementary treatment, which is quite new, it has limited evidence. It's just because it's just new. So they just want further study to it, is laser. So laser like Mona Lisa Touch, Erbium Laser in Australia, it's TGA approved. So you could actually go to a place where they offer vaginal rejuvenation, and it does actually help tighten, and then it just forms a scar under the neck of the bladder to hold it up. Instead of, if it's quite relaxed, it just goes down, that's why you leak. But if it does form a scar under there and it holds up, you could hold it better. So yeah, it's actually approved by the RANSCOG, by the Royal Australian New Zealand College of Obstetrics and Gynecology College. So we'll go to the next one, please. And another thing is the platelet-rich plasma. It's approved, TJ approved. Any platelet-rich plasma is approved by Australian TGA anyway. And then autologous blood means it's your own blood, the same as when you do PRP on the face. So it just helps stimulate the mucosa around the area. Even if you have that, you know, the labia minora, labia majora is like no fat at all. You could have fillers and then put on PRP, and they do actually stimulate the growth factors so that they proliferate the stem cells to form their own collagen there. So it's It's, you know, you need the same as when you have your PRP on the face. We could get that rejuvenation because it helps with the moisture. It helps with the collagen so that it wouldn't sag too much, and tightening as well. So with the next slide, so the next one, you could see that they've actually done in 2010 a study where they did autologous lipofilling with PRP and then added on fibrin in it. And they found out that there's vaginal vascularity, there's like new blood vessels that came up, and it actually helped atrophic, or meaning old, more than 65-year-old skin area there to become thicker and firmer. So like moisture as well as helping with tightening did help, because it helped with the ligaments and muscles as well. It becomes stronger. So it did help mild urinary incontinence with this research. So that was 2010. So lots of research for now, but yeah, I haven't picked up any recent ones. We go to the next one. I think the last slide we have is just the cervical cancer screening. So I'm not going to delve into much to that, because I just want to make sure that you know that instead of every 2 years, we're now every 5 years with that. Anybody who hasn't had their pap smear from 2017 should have one. So between 25 to 74 years old, or even earlier, if you have symptoms of post-coital or after intercourse bleeding, or intermenstrual bleeding, or postmenopausal bleeding, you need to have your pap smear done regardless of age, regardless of when you have your last pap smear, even if it's normal or abnormal, you just have to get it done. Otherwise, if you don't have those earlier symptoms of cervical cancer, you do it every 5 years. So I think that concludes it, Victoria.